Cancer, the emperor of all maladies. It is so named for a reason, as cancer is not a single condition, but rather a collection of diseases. Oncology does not deal with just one anatomy, like cardiology, or with one condition like rheumatology, but rather specializes in the broad spectrum of tumors, primarily only having one thing in common. A patient's own cells become abnormal and alien to its own body. With such a vast variation in which tumor cells become malignant, many compare the search for cancer remedies to an arms race. On the other hand, targeting just the cancer cells selectively without harming the patient makes therapy choices and delivery difficult. My name is Dr. Ilya Gipp, and I'm the Chief Medical Officer for Oncology at Philips. This short video is intended for educational purposes only. Views and opinions reflected in this program may not necessarily reflect those of my company. As a physician, for the last 2.5 decades, I have witnessed quite some progress in cancer care. Today, not only do we understand cancer better than ever before, but we are able to reduce its burden significantly. In just the last 20 years, the age-standardized cancer death rate dropped by 15%. And in the United States alone, the risk of dying from cancer has fallen 32% from its peak in 1991. That's approximately 3.5 million lives saved. So it would be fair to say that improvement is significant, and oncology is moving in the right direction. But while our knowledge about cancer is growing at an unprecedented pace, we are overwhelmed by the amounts and the complexity of information. To make optimal decisions, ensuring best outcomes and cost, an oncologist needs now to consider over 10,000 data points per every case. Cancer patients face this complexity too. Besides experiencing physical and emotional burdens, a patient needs to see multitudes of professionals and make hundreds of visits. It is no wonder that no-show rates that result in clinical misses and financial losses are overwhelming. Both the number of discovered cancer variants as well as treatment options are rapidly expanding. Patient numbers continue to grow. Thus, the necessity for value-based cancer care is not only increasing, but is becoming compulsory. What can we do? Collaborative approach requires communication. Cancer care professionals are realizing this reality and need. As a starting point, they're getting together for multidisciplinary tumor boards. Again, progress in the right direction. But how efficient would the tumor board be without commonly available, meaningful data that adds value to their endeavors? To me, better cancer care is where all stakeholders are enabled to have access to objective and actionable data precisely at the moment when it is essential for them to make the best possible decision. These days, professionals might be so exclusively specialized that in meetings it might sound that they are not speaking the same language. And by narrowing their contribution down to their incredible but siloed expertise, we risk the danger of coming together, all being blind of each other's findings, insights, and ideas. It was 6 men in Hindustan, to learning much inclined, who went to see the elephant, though all of them were blind, that each by observation might satisfy his mind. At the tumor board, the radiologist may have quantitative information about the tumor and insights on the way it will respond to various treatments. Or during or after therapy, while changes are still reversible, they may see early signs of side effects. Blood biomarker test results may contain assessment data on the risk of cancer subtype for the patient and be valuable for how aggressive the treatment should be. The pathologist, in addition to definitive information on histologic diagnoses and staging, may have molecular signature data that could be critical not only for prognosis prediction, but also for progression detection and guidance of next-line therapy options. The interventional oncologist may see a patient as a candidate for focal and organ-preserving therapy rather than a more radical treatment. Medical, radiation, and cardio-oncologists, surgeons, may need evidence that discussed treatment option is the best from the standpoint of clinical efficacy and financial efficiency. The danger of missing the complete picture is that it may not only prevent the cancer care team from making the best choices, but will as well complicate their adoption of novel diagnostic, therapy, and follow-up options. And lacking evidence from outcomes will inevitably make value care principles harder to accomplish. The ending of the story about the blind man and the elephant is that we all want to avoid. And so these men of Indostan disputed loud and long, each in his own opinion, exceeding stiff and strong, though each was partly in the right, and all were in the wrong. So the elephant in the room is data that is discrete. All cancer care professionals these days may have valuable pieces of information in their possession, but existing silos and barriers are limiting its meaningfulness and actionability, and make oncology stakeholders to be only partly in the right, and sometimes just downright wrong. Whether we take prostate, breast, lung, liver, or almost any other cancer as an example, everyone dealing with a disease is in desperate need of the tools that not only support the collaborative approach, but also ensure timely access to what really matters. Like in the composer's music sheet, connected care requires coordinated orchestration of objective information. Better cancer care is totally achievable, and seamless data management is one of the keys to it.